In terms of Marburg virus disease outbreak, as Madam PS has alluded to, yes, on 20th of this month, the United Republic of Tanzania confirmed one case of Marburg virus disease in northwestern part of the country. For opening this session for us, giving a broad overview of the state of health of our nation in terms of the implementation of Taifa Care, our model for delivery of universal health coverage. And just to be able to echo what Madam PS has said is that now we have breached the 18 million registration number. We are actually at 18,243,000. However, our appeal is for us to ensure that as those who have registered, we go the whole way to ensure that we add our dependents. And as PS has indicated, we are going to work with the community health promoters to ensure that the assisted journey in terms of registration, including adding the dependents, is accomplished. In terms of claims submitted, and we are joined here by the acting CEO of Social Health Authority, since the inception of the program on 1st of October last year, 660,000 claims totaling 14.6 billion have been lodged on the portal, broken down as 8.5 billion for the private and the faith-based facilities, and 4.8 billion for public health facilities. Some of the top counties which have lodged their claims include Kisii, which has lodged claims totaling 770 million, Kisumu 649 million, Kiambu 621 million, and Homa Bay 521 million. Nearly 1 million Kenyans have been able to access the primary health care services. Remember, our approach towards rollout or implementation of Taifa Care is based on a primary health care approach, because primary health care systems tend to be comprehensive, integrated, and promote equity and inclusivity in terms of health service delivery. So we are pleased that nearly 1 million Kenyans have accessed primary health care services. And remember, the primary health care fund is fully financed by the Exchequer. The number of pre-authorizations has also reached more than 300,000. And as the system stabilizes, we expect these numbers to be on an upward trajectory. We have responded to the calls from Kenyans regarding the extent of the menu we are providing in terms of the benefits package. And as a result of that, under Section 41 of the regulations of the Social Health Authority, the Cabinet Secretary and the Principal Secretary, State Department of Medical Services, have instituted measures to be able to ensure that the benefit package tariffs advisory panel, which is envisioned in law, is then in place. And the indication initially was that we are supposed to review the tariff and benefits after 2 years, but because of the call from Kenyans regarding their experience with SHA, that will be done much sooner. And therefore, once this team is in place, it will review the existing benefits package and the tariffs applicable, that is what we pay the providers, and the health interventions that are not locally available to enable Kenyans access treatment outside. It will be a scientific process, all inclusive, involving all stakeholders in terms of accountability. In terms of vaccine status, in our conversation last week, the country has been grappling with a shortage of the BCG vaccine, which is supposed to prevent us from getting tuberculosis. And we have disclosed that before the end of the month, we are supposed to receive 2.3 million doses of the vaccine. I want to affirm that we received the vaccines the day before yesterday in our Kitengela stores, and distribution of the vaccines have commenced to the 9 regional depots. Nairobi has been allocated 450,000 doses, Kisumu 300,000, Kakamega 276, Nakuru 264, Mombasa 120, Meru, Nyeri 90,000 each, Garissa 120,000, and Eldoret 290,000. And we have kept a stock of 234,000 doses at the national level to be able to maintain the buffer stock. In terms of logistics, usually we are supposed to keep 6 months worth of stock at the national depot to ensure that at any given time we don't run out of the vaccines because of the long supply chain pipeline. We also are in the process in the next 1 to 2 months, end of this month to early February, we'll receive additional rotavirus vaccine, which is supposed to prevent diarrhea in children, tetanus diphtheria vaccine, and pentavalent vaccine, and also oral polio vaccine. So our vaccine situation is going to improve in the next 1 to 2 weeks. Our appeal is to the parents, guardians, and caregivers to be able to bring all children who missed out on the BCG vaccination to the facilities because the vaccines are now available, but also appeal to the counties to be able to set up outreaches and in-reaches to be able to reach those children who missed on their vaccination. We are working with the National Assembly Committee of Health, civil society, all stakeholders to ensure that we have financial sustainability in terms of procurement of our vaccines. And we are committed to preventing all vaccine-preventable diseases. In terms of Marburg virus disease outbreak, as Madam PS has alluded to, yes, on 20th of this month, the United Republic of Tanzania confirmed 1 case of Marburg virus disease in northwestern part of the country. And remember, Tanzania also had expressed a Marburg virus disease outbreak in 2023. Also in our East African Community region, the Republic of Rwanda had an outbreak of Marburg virus disease from September, October, and that was declared over in December, on 20th of December last year. Marburg virus is closely related to Ebola virus. They belong to the class of viruses called filoviruses. And we know the devastation these kind of viruses can be able to cause if we have established community transmission. The countries of Liberia, Guinea, and Sierra Leone in total lost more than $4.5 billion in productivity in the 2014-2016 Ebola outbreak virus disease. In terms of presentation of this virus, the source of this virus is usually fruit bats, which tend to stay in caves. Therefore, people who are hikers or miners who get into such situations then can easily get exposed to the virus. Outside that realm is that the virus can only be transmitted from person to person through bodily fluids like blood, vomiters, or in one getting into contact with a contaminated surface. The presentation is usually by acute onset of high temperature or fever, severe malaise, severe headache, severe abdominal pain, nausea, vomiting, and cramping. And about 5 to 7 days later, the bleeding manifestation of the disease tends to elicit. And death does occur usually 9 to 10 days later as a result of shock and out of severe bleeding. So our call to action is that communities are very, very important in bringing such an outbreak to an end through community mobilization and advocacy to communities. Outbreaks, epidemics, pandemics begin and end with communities. As health experts, what we do is just to be able to enable the communities to bring them to an end. And therefore, community engagement is important. Then infection prevention control measures that Madam Pierce alluded to, hand washing, or using a disinfectant or alcohol-based disinfectant or sanitizer is critical. Already, because we have had these outbreaks since 2023, we are permanently on alert model. And therefore, our surveillance system will continue. We are ready to be able to commence contact tracing. If a suspected case emerges, we have the necessary diagnostic capacity to be able to provide a diagnosis for the virus. And of course, case management, because early supportive case management of Marburg virus disease leads to better outcomes. And of course, because of communities, safe, dignified burials, following lessons learned in Ebola in 2014-16, then becomes paramount. With that, we don't have a specific treatment in terms of a vaccine or antiviral medication for Marburg virus disease. Therefore, prevention becomes critical. Turning over to Mpox, which Madam PS also mentioned, we as a country we have reported 36 cases cumulatively. Currently, we have 2 cases under active management in a health facility, 1 case under home-based isolation and care. And we believe the measures we put in place have ensured that we have not had established community transmission of the virus. In terms of the US leaving WHO, we saw the pronouncement by President Trump upon his swearing in. And we want to reiterate that US is one of the founding members of the WHO, and currently its major donor, contributing nearly 20% of the total budget. The budget for 2024-2025 WHO budget is about $6.8 billion, and US contributes about 18%. And our plea is that collectively we are safer together as a whole world, while individual countries, because WHO is a member states organization, individual member states are at liberty to be able to take any decision that suits them. However, we appeal that following lessons learned from most of these outbreaks, we are only safer together as one global community. And it is that global community that has done a lot in terms of disease prevention, in terms of identifying diseases, building resilient health systems, and ensuring the safety of the global health community. Thank you.